Good morning, good afternoon, and good evening. I hope everybody is doing great. Today we are going to talk about abdominal pain. So, abdominal pain is one of the high yield topic when it comes to MCCQ1 and NAC. So, very high yield. You really need to know everything about abdominal pain before you attempt MCQ1 or NAC. And today we're going to cover almost everything that you need for the MCQ1 and NAC. More focus on NAC side, but I will point out a few essential things that you need to look out for the MCQ1 as well. Okay. So by the end of this lecture, you should be able to know how to run safe, structured approach to the undifferentiated abdominal pain, including extra abdominal causes, um, recognize and act on red flags requiring resuscitation, urgent imaging, and/or immediate consultation. Perform a focused history and exam that earns OSCE marks, including the GU and gynae when indicated. Select initial labs and imaging rationally, ultrasound versus CT scan, communication uncertainty, plus provide clear return, precaution, safety net. So basically, these are the things that you need to know when you're dealing with abdominal pain in general. And I make sure by the end of this lecture, you guys know every vital thing about abdominal pain, whether you're attempting NAC or MCQ1, okay? Especially NAC. So approach safety first, then precision. So what examiner want to hear from you? We're talking in general. We're talking in general about the NAC. If you have a case of an abdominal pain in general, what an examiner wants to hear. So I will first assess stability and rule out life-threatening cause. So when you're dealing with abdominal pain, you need to make sure that the patient is stable enough and you are in a better position to rule out the life-threatening cause. For example, you cannot take a history from somebody who has abdominal aortic aneurysm rupture, right? You don't even have time. You don't even have time for imaging. Forget about history taking. So when you say this, that I will first assess stability of my patient and rule out the life-threatening cause, it means you know what to do step by step when you're dealing or approaching an abdominal pain patient. So ABC, vitals, mental status, attach monitor if unwell. Early analgesia plus reassessment is appropriate. If you notice out of all of these, I made this one red. Why? Because there's a false perception that IMG is saying that if the patient has pain and if we use painkiller, it will negatively affect the patient's diagnosis. So remember that you cannot do history taking, you cannot do consultation, you cannot do anything unless the patient is comfortable enough. Like if you have a patient who has excruciating pain and you're just sitting and you want to do the history take, even if it is clearly says the take history, and when you enter to the station and your patient is in excruciating pain like this, he's moving right and left and he's not comfortable, you cannot take history, even though that's the only thing that you need to do. So you make sure that you offer painkiller first. So I see that you're right now, you're having an excruciating pain. So let's stop here. Let me provide you with a painkiller. Once you're okay, then we continue. As soon as you say this, then the patient will drop the act. And the patient says, you know what, let's do it. Or imagine that you gave me the medication. Now I'm much better in a better position to continue. Let's continue it. They're not going to waste your time. They just want to check if you know what to do if the patient is in pain. Just remember this, very important, okay? Or even if the patient, when you're taking the history, you know the OCD, PQRST, UV, triple A, right? That mnemonic. When you're applying that, when you get to the severity and you ask the patient in terms of severity, 1 being the least amount of pain, 10 being the most amount of pain, how much do you scale the pain? And the patient says 9, 10. Oh, I'm so sorry to hear about that. Can you continue? Do you want me to stop and provide you with a painkiller? And the patient says, no, you know what? I'm fine. Let's continue the history taking. But they really, I mean, the examiner expect you to mention this. And the examiner is actually wants to hear what exactly what I said to you. Like he exactly wants to hear that you care and you are there to provide the painkiller. Analgesia first, then do whatever you need to do. Whether you're doing CT scan, imaging, physical examination, history, consultation. If the patient is in pain, stop everything, provide painkiller, then move on. Okay? So target differential based on the location, patterns, and patient's factors. Clear plan. So what are the plan that I need to have for approaching a patient who has abdominal pain? So the examiner exactly wants you to think it loudly. It means you need to speak up when you're doing it. I need to do the test. What are the tests? Then mention CBC, electrolyte, this and that, LFT, liver function test, RFT, whatever. Just mention it, and you have to verbalize it. Do not think that this is so easy and basic. The examiner knows that I know it. He doesn't read your mind, so you have to speak up. Okay? Imaging, I would do ultrasound, I would do CT scan, I would do MRI based on your patients, based on the condition, but you have to mention that I do these tests and then I move on to the imaging if I'm not convinced. Consult, how do you consult? And disposition. So, can misdiagnose. These are the things that you have to rule out and you cannot miss it. All right. So please keep your mics off. Thank you very much. All right. So abdominal aortic aneurysm, leaking aneurysm. This you have to mention, and you have to, if you're taking a history, you have to do or those specific questions so that the examiner knows that you're trying to rule out abdominal aortic aneurysm. So you cannot miss this because these are the red flags and you have to rule them out. If you do not rule out these red flags, you're in trouble. You're losing a big portion of your mark because they expect you to mention and rule out these conditions. Not like specifically mention, I'm very worried about aortic and abdominal aortic aneurysm. So do you have this, this, this? No. When you're asking a specific question, for example, about the age, about, for example, the weight of the patient, about, for example, the social life of the patient, for example, the smoking stuff, then yeah, indirectly you let the examiner knows because these are the risk factor for abdominal aortic aneurysm, and my patient does not have it. Okay, but you have to rule it out. Mesenteric ischemia, pain out of proportion, very characteristic, very characteristic. Perforation peritonitis, obviously the abdomen will be stiff, rigid, like board-like. Bowel obstruction, not only the patient has pain, the patient will have constant vomiting. Ectopic pregnancy. Ectopic pregnancy, if the patient is in the stage of being, for example, in the age of conception, and the patient has pelvic or lower abdominal pain plus bleeding. So it is ectopic pregnancy until proven otherwise. Ovarian torsion, testicular torsion. So when did it happen? And how is the pain? Is it one side or both side? Did it happen when the patient was, for example, doing intense workout, or he was engaging in sexual activity, or what? Because usually if they test you, even for the MCQ one, if you're preparing for an MCQ one, if they want to test you on ovarian torsion or testicular torsion, they usually give you a scenario about a young patient that who was engaging in a very strenuous or intense activity, for example, working out. Or they will give you a scenario about these young female or male who was engaging in sex and then suddenly happened, but it is one-sided. It is one-sided. Okay. And yeah, the first 2 minutes stabilize and stratify risk. So ABC, monitor, 2 IV line, if unwell, IV fluid, if shock, types and screening, if bleeding, NPO, if surgical concern, early consult if unstable. So these are the things that you do for stabilizing. And you need to probably get a question. How do you stabilize the patient? Right? So I do this ABC, I do the monitor, I open the IV line, IV fluid, I do the blood work, the type and the screen of the bleeding, NPO. I do NPO if I'm worried about something serious that would need an urgent surgery. So I have to stop everything, including the medication the patient is taking, everything I will switch it to IV. Early consult if unstable. So bedside essential, these are the things that you get usually asked by the examiner. So what do you do? What do you do, or what are the bedside essentials? So pain score, reassess, urine pregnancy test, if possible, urine analysis, stone, or if I'm suspecting uh, a stone or UTI clues. So ECG, if epigastric upper abdominal pain, and the patient has the risk factor for the acute coronary syndrome. POC, glucose if altered. Now, red flags, what are the red flags that you need to act now? Like if my patient has hypotension and syncope. Why? Because it might be a massive intra-abdominal bleeding. For example, splenic rupture. If my patient has a history of like recent history of a motor vehicle accident or a direct trauma into the abdomen, especially in the left upper quadrant, and the patient just have a hypotension and syncope. So I think more like it would be more like internal organ massive bleeding, which is most likely splenic rupture. Peritonitis, if my patient has all those characteristic finding, for example, the tenderness, board-like rigidity of the abdomen and pain out of proportion, and also the physical finding doesn't match with the pain, like the patient has excruciating pain. And GI bleeding plus instability, pain out of proportion, which is very characteristic for the mesenteric ischemia. Persistent vomiting, always think if the patient has abdominal pain with persistent vomiting, we always think about obstruction. And pregnancy plus pain plus pelvic pain plus bleeding in a woman in conceiving age is always ectopic pregnancy until proven otherwise. Focus history high yield. This is something that if you don't know it, I don't think you would be able to finish or start any station. So OCD curiosity, UV O stands for onset. Was it sudden? Was it gradual? It helps you. The course, the duration, position, where is it? Point with your finger. Quality and character. Is it colicky? Is it constant? If it is colicky, what does it mean? It is usually obstruction. If it is constant, it means this is more like inflammation, like IBD. So these are the most important points that you cannot miss when you're taking history. If you miss this, then it means you're going after the wrong diagnosis, or you will have a wrong diagnosis at the end. So radiation, back, shoulder, groin. For example, if it is abdominal pain that radiates to the back, we usually think about the pancreatitis. right? If it is, for example, pain on the right upper quadrant and radiating to the right shoulder, on the right side, acute cholecystitis. If it happens on the left side, it is usually spleen, right? Or pancreatitis again. Or if it radiates to the groin, or if it radiates to the right testicle, if uh, the patient has a stone in a ureter, so it will radiate to the right side and radiate to the right testicle. But if it is a female, it will radiate to the low side or right lower right groin or right labia, right? So radiation of the pain helps you to pinpoint or come up with the right diagnosis. That has to be asked. Severity, again, on a scale of 1 to 10, you have to know if it is very severe enough and share your empathy with the patient and offer painkiller. Time, what time of the day? Does it happen in the morning? Does it happen like in the lunch? Is there a specific time that happens? It really helps. Your daily activity. This is very important. It shows how severely it affects you and how serious we have to take it, because it's something that it is just there but it doesn't bother you. You can do study, you can go to work, it doesn't affect your daily life, so they're not going to take it very serious. But still they think they will do the investigation, but they're not going to like rush it, right? So you're not emergency, but they will take their time to do the investigation. It really matters. But if you say, you know what, since I have it, I haven't gone to school because it is so severe that I cannot focus, or I have missed my work for a few days. Now it means there is something seriously going on that we have to find it. The sooner, the better, right? So it really matters. And deja vu, does it happen for the first time or you have it from the past? Associated sign and symptom, which we can, uh, let me add, sorry guys. All right, I can add this. So I have it here. Yeah, that's just a sign and symptom. For example, vomiting, anorexia, fever, rigors, diarrhea versus obstipation, GI bleeding, urinary dysuria, hematuria, jaundice. So, on top of abdominal pain, is there any other associated sign and symptoms? For example, vomiting. It will help you. Does it have fever? Because let's say it is biliary colic. You have pain, but usually you don't have fever. So it really helps you to know whether it is biliary colic, if it is on the right upper quadrant, or it is acute cholecystitis, right? Do you have nausea, vomiting? No, I just have nausea, right? Okay. Do you have fever? No, I don't. So if the patient doesn't have it, it just helps you to lean toward to the biliary colic than acute cholecystitis. GI bleeding, urinary sinus symptoms, and so on and so forth. Jaundice, for example. Cholangitis. If the patient has pain plus systemic symptoms plus jaundice, obviously it is cholangitis. So it really helps. You cannot miss it in the history taking. Elevating factor, what makes it better and what makes it worse. For example, I'm going to give you an example. If the patient has abdominal pain, but the patient says, when I lean forward, it gets better. So it actually elevate the pain, right? So it gets better. But when I uh, stretch backward, or I want to, if I sleep in a supine position facing up, it gets worse. So you know this is pancreatitis. So elevating factor, aggravating factor really helps to pinpoint the right diagnosis. Now, in terms of age, comorbidity, virility, uh, it really matters because some of those conditions are very specifically for specific conditions. It doesn't mean that it doesn't happen to add any other ages, but in terms of age-wise, some of these condition happens usually in, for example, elderly. I'm just going to give you an example. For example, diverticulitis. Diverticulitis can happen in young patients, but it's more common in elderly. So age plays a major role, which you cannot forget. Prior abdominal surgery. Why does it matter? Because usually if the obstruction happened or if the patient has history of surgery, it could be adhesion or obstructions due to adhesion, right? So I know what is the cause of this obstruction. So always ask about the past medical history. NSAID, anticoagulants. Why? Because it really matters if my patient is bleeding inside. And vascular disease, pregnancy, possible last minister period, as I mentioned before, all these stuff has to be asked, STI risk and discharge. Focus exam, most from the pattern and completeness. Appearance, so general and vitals. If I have to focus, like in a physical examination, if I'm dealing with a abdominal pain station, so what is the first best thing? Obviously, knock the door, then you enter, smile, greet everybody, use the hand sanitizer, hand over your ID, I mean the number, the student number to the examiner, which in these days they don't do it anymore. You just call your student number and the examiner finds your paper and he knows, oh, I have your paper, now I can give you mark. If you don't say it, then he has like a bunch of papers and he doesn't know who you are so that he can mark you, right? So you have to introduce yourself to the examiner so that he find the right paper to give you the score or the mark. And then you introduce yourself and ID the patient and explain your rule. I'm here to perform physical examination on your abdomen and your belly. Don't use abdomen, on your belly. Lame term, right? The medical term for the examiner, lame term for the patient. I'm gonna perform a few physical examination on your belly. By physical examination, I mean I will take a look at your belly. I will touch your belly. I feel it, and I probably perform some maneuvers. But I will stop if it is painful. I will try my best to keep it as comfortable as possible, but at any time, if it starts to hurt you, please let me know and I will stop right away. And the patient says, thank you. And can we start it? And the patient says, yes, sure. So you introduce yourself, you ID the patient, and then you explain your rule, why you're here, right? And then you ask the patient for the consent. This is basic stuff that you need to do before engaging to the patient because you cannot touch the patient unless the patient says, I'm okay, let's do it. So you have the general consent, now you can start. So appearance, now you have a general inspection, then you have a focused inspection. Always start with a general inspection. My patient is sitting, I'm just giving you like, you need to comment on the appearance, on the vitals and everything. But let's say, if I make it very simple for you guys, you comment and report it to the examiner like in a general way. How? For example, my patient is sitting in the corner of the bed and the patient seems to be in no pain or he's doing well. Or my patient is sitting in the corner of the bed and he seems to be in a lot of pain. So what this is a general inspection. He looks fine. I don't see any sign of jaundice. I don't see any sign of panicking or these stuff, like the basic and general thing that you can see while you're inspecting your patient, right? General thing. Based on the patient, based on the condition, it will be a little bit different. For example, if you're dealing with a neurological case, then you have to look around and see if the patient has any walking aid or a wheelchair, right? If he has, you know that the patient is having trouble walking. So my patient is sitting on the bed of the chair. The patient is moving the right limb, but he's not moving the left limb. And I can see there's a wheelchair on the side of the bed. So it means my patient came here with a wheelchair. These are the general inspection. and you comment on everything. And my patient is breathing fine, or my patient is breathing very rapidly. So these are the things, whatever you see, general, that's a general. Then you move on to the focus. For the focus, regardless of where you're inspecting, whether it's face, it's neck, it's chest, it's abdomen, it's knee, it is pelvis area, wherever it is, cover the seats. What is the seat? Swelling, erythema, atrophy, and deformity, distension. For example, for the abdomen, distension, right? Deformity for the other area, like for example, in joints or bone area, deformity. Face, deformity, right? And distension. And then scars from the previous surgery. And hernia. It's up to you if you want to mention it. If not, if you have it, report it. If not, but in this case, since we are focusing only on abdomen, then we have to, right? But in face, you don't say hernia. But I'm just saying, in a general, regardless of where you are doing the focus exam, whether it is face, neck, chest, abdomen, pelvis area, or the joints, seats, swelling, erythema, edema, erythema and edema, okay? Erythema, edema, atrophy, deformity, and scar. So just remember erythema and edema, because if it is joint, then you're looking for the edema as well. But it's still the seat. Remember the seat, memorize it, always apply it for the focus inspection, not general inspection. General inspection is general, as I mentioned before. Now, after an inspection, for the chest, it is different. For the abdomen, it is different. We usually don't do the percussion and palpation in the abdomen. Why? Because the percussion and palpation of the abdomen will either stimulate or suppress the activity of intestine. So if you do the percussion and palpation and then you do the auscultation, the sound that you hear is not a valid sound because you have either stimulated or suppressed it. So as soon as you're done with the focus and inspection, the next thing that you need to do, you need to do the auscultation. I'm not going to go through that because we will do it in person in the class, because you need to know where to put your stethoscope to hear the proper sound. So palpation, tenderness, guarding, rigidity, rebound, then percussion. Okay. Don't forget pelvic exam, gynae exam, again, same thing with when we are discussing about the ectopic pregnancy. Testicular exam for torsion and hernia orifices, and rectal exam only if it changes if it changed management. You just mention it if you have to do it, but we never do it. We never ever do it. So the patient requires digital rectal exam, but I'm skipping it. But it doesn't mean you don't have to mention it. If it is required to be done, you just speak it up, okay? Don't pretend or don't think that I can't do it here. An examiner knows it. No, don't say that. Don't think that way. If it is digital rectal exam, it means you have to do it. But since it is exam, you're not required to do it, but you have to mention it and skip it. So just mention that the patient requires to have, or I'm required to do a digital rectal exam for the patient, but I'm going to skip it now for now. And the examiner will, thank you very much, move on. But if you don't mention it, you definitely lose a mark. Okay? All right. So analgesia, I think we did talk about this enough that we cannot ignore it. If the patient is in pain, you need to give him the painkiller. I will give painkiller relief now and reassess. Analgesia does not reduce diagnostic accuracy. This is very important. Remember, sometimes you might get a case that you have an abdominal patient, a station, and as soon as you get into the station, the patient is in excruciating pain, or at the middle of the history taking, suddenly he says, you know what, it is getting worse right now, I can't even talk. And he wants to see if you know that you should stop right now and offer painkiller for the patient. So if it happens, you offer. If you don't offer and you still, I know you're in pain, but still we have to finish this, otherwise I cannot help you and I don't know what is the cause, don't do that. Okay? Please stop and most of the time they will drop that. Initial test, CBC, electrolyte, creatinine, glucose, urine analysis, and culture. Beta ECG for all the women in conceiving age. Add lactate. You cannot forget this. Lactate, ABG, VBG, if shock or ischemia is suspected. So you don't do it for everybody. But if you're suspecting, then in that case, you need to add the lactate and ABG, VBG. So right upper quadrant, jaundice, LFT, bilirubins, and for epigastric pain, for all of them, you need to do the lipase and upper abdomen, especially old. If you have a patient who comes with an upper epigastric pain, always do an ECG because inferior MI in some cases does not come with a chest pain, it comes with a upper epigastric pain. So you cannot forget this. And they want to hear that you say, since my patient is an elderly and my patient has upper epigastric area pain, so it is always good to do an ECG to make sure it is not inferior MI and you will impress the examiner. Okay, bleeding, surgery. Always, if the patient is bleeding, or if you're suspecting that my patient might be bleeding or my patient is going to have a major surgery, coagulation, type, and screening. Ultrasound, biliary plus pelvic pathology, CT scan, remember, anterior posterior obstruction, diverticulitis, perforation, adult appendicitis. So there is something that I have to mention. I think we have it in the next slide as well. I think we can discuss it in the next slide. So remember here I have to add PETs and preg, or maybe pregnant. Yeah, pregnant appendicitis. So in pediatric, so you might get a case that you have a young adult with a characteristic picture of appendicitis, and they will ask you what is the best imaging for this patient. It is always CT scan, and they might give you a child, and then the patient has characteristic find of appendicitis. What is the best imaging? Ultrasound, or they may give you a scenario about a pregnant woman who has appendicitis or a characteristic finding of appendicitis, and she needs to get an imaging done. So again, for the pediatric, ultrasound or MRI, not CT scan. Okay. And again, I know it's so basic, and most of the time you're like, everybody knows this. Why we bother talking about it? But the examiner really needs to hear it. Okay, he is not a mind reader. Like, you have to mention that this is what it is. Since this patient is a child, I prefer not to go for the CT scan. I prefer to do the ultrasound. They want to hear it. Okay, to go. That's why it's not only your knowledge. It's about um, going and following the ethics of the country as well. Okay, and being a safe person when you're dealing with the people's health. All right. So localize the pain. I think I don't have to bother mentioning this. Everybody here knows when it comes for the location of pain, right upper quadrant, epigastric, right lower quadrant, left lower quadrant, flank, and diffuse. Obstruction usually diffuses obstruction, ischemia, and peritonitis. The rest everybody knows, right? So I'm going to skip this slide. It is very basic. So recognize peritonitis. I think we did talk about this as well. If the patient has rigid, board-like abdomen, rebound, guarding. So remember, these are the characteristic or the clues when it comes to peritonitis. Whether you're doing MCQ1 or NAC OSCE, if you see rigid, board-like abdomen, rebound, guarding, think about peritonitis. It is peritonitis, unless it's proven otherwise. Okay. So if you have a scenario behind the station and you read and you have this thing, it is emergency case. Okay. And usually they don't give you an emergency case. But if it mentioned, you need to know that I'm dealing with something very, very emergent. Okay. Pain with movement, cough, and another clue that gives you a signal that, remember, it is urgent. It could be peritonitis, so be prepared. Okay. So based on that, you have to map out your plan, how you want to approach it, right? For example, if it is like this, so these are the things that I have to order. For example, lactate. You cannot forget about that, right? Consider perforation, ischemia, and complication, uh, appendicitis, diverticulitis, resuscitate, ABC. So immediate action. So let's say you recognize peritonitis, or you're still suspecting that this case might be peritonitis. Then what is the immediate action? Resuscitate, ABC, IV access, fluid, analgesic, including the lactate. I have to do this. If you notice, this is red. They want to hear this. And if you're doing MCQ1, this will be in the scenario if they are talking about necrosis or ischemia, especially necrosis, types and screening if needed, broad spectrum antibiotic. Remember, we don't normally use antibiotic unless it is sepsis or infection is suspected. Infection is suspected. So early surgical consultation, do not delay if the patient is unstable. If the patient has abdominal pain, the patient is not stable, then it is emergency. You need to consult with the surgeon. Okay. Right upper quadrant pain, biliary disease. I think we did talk about this one. Biliary is usually episodic, post fatty meals, afebrile, no peritonitis, and it is usually less than 6 hours when it starts, right? Acute cholecystitis, persistent right upper quadrant. It is episodic. This is persistence, right? It's less than 6 hours. It's more than 6 hours. The patient does not have fever here. The patient has fever here. Leukocytosis. Murphy sinus positive. Cholangitis, the patient will have jaundice plus systemic toxicity. So these are the lab: CBC, LFT, bilirubin, plus minus lipase. If it is epigastric area, always include this. Right upper quadrant ultrasound is the first imaging. This might be a question in the licensing exam, MCCQ1. What is the best initial imaging for someone who has right upper quadrant pain? Always ultrasound. Supportive, fluid, analgesia, antiemetic. If infection is suspected, antibiotic plus early consultation. So your symptoms suggest gallbladder disease. So the OSCE phrasing. So your symptoms suggest gallbladder disease. Like you have a patient and the patient has upper quadrant pain. So upper quadrant pain could be, especially if the patient has episodic or persistent right upper quadrant pain. So it has something to do with the gallbladder, right? And you start with like this for the patient. Your symptoms suggest gallbladder disease. I will order an ultrasound and blood test and start pain control. Since you have pain, I will offer you the painkiller. But since you have right upper quadrant pain, now I have to differentiate it. I have some idea based on the clinical finding, based on the symptoms that you provided me, but I would like to make sure which one is which. So I'm gonna do an imaging, which is the ultrasound. At the meantime, since you're taking the medication, it helps you with the pain, and we have to do the imaging as well. So I will offer the ultrasound as well. It will help us to differentiate. If infection is suspected, we will start antibiotic. These are the things that you're walking the patient through. So if it is infection, then we'll provide you not only the painkiller, we will provide you with the antibiotic as well. And if it is something urgent, then we do the surgery. I will reassess you frequently and review your vital signs closely. So the patient is in good hands, and the patient can trust you because he and she or she might he and she will know that you care about his or her health, and she know that you're going to be every step of the way with him or her. Okay, so you mentioned every step that you're doing. So by now, I think we know what is the biliary colic and what is the acute cholecystitis. So a few things, it will be transit, it will be episodic, it will be less than 6 hours, usually after fatty. This one happens as well, but usually it doesn't have systemic symptoms, like it doesn't have leukocytosis, fever, and so on. This one has high WBC, leukocytosis, CRP, and also the patient will have fever as well. And for both of them, we do the same thing. We do the ultrasound. Good. Only the different the treatment is different from biliary colic and acute cholecystitis. So appendicitis, I don't think we should waste any time because it is very basic. Everybody knows it. Preumbilical area, then it migrates to right lower quadrant, anorexia, fever. So imaging, we did talk about this. Early surgical consultation or high suspicious. If pregnant, ectopic pregnancy until proven otherwise. Again, you have someone who is at conceiving age and she's bleeding with a pelvic pain. It is ectopic pregnancy until proven otherwise. So what do? I do an ultrasound, OBGYN pathway as indicated, and also I will order the beta ECG. Do not delay the stabilization in unstable patient. So ovarian torsion, abrupt, severe lower abdominal pain, often with nausea and vomiting. It is variable. Remember, for this one, usually they give you a scenario about someone that this torsion happened during activity, whether she was engaging in mowing the lawn, or she was just exercising in the gym, or she was just having, for example, sexual intercourse or something, but she was at the middle of a physical activity. Same thing with a male as well, young, and he was, for example, exercising or was engaged in a sexual activity, or he was, for example, mowing lawn, or he was running, playing around, this and that. Uh, Imaging should not delay. I think we did talk about this, so we're gonna skip from this slide. Left lower quadrant pain, very commonly tested, very commonly tested, especially diverticulitis. So often localized left lower quadrant pain plus low-grade fever. Many patients can be treated as an outpatient with a non-opioid analgesia. Antibiotics are not routinely required. Remember, the reason I put it red because most commonly mistaken, IMG most commonly are getting this question wrong, and the reason they get it wrong, they offer antibiotic for everybody, and I don't blame them because I'm talking for myself. In Afghanistan, if you have left lower quadrant pain, it is just they have to start the antibiotic. But here we don't start it unless it is required. Even if the patient is treated as an outpatient, good thing that I remember. So when it comes to antibiotic, a few things I have to raise here. So if the patient needs antibiotic, the patient has systemic signs and symptoms. Like in this case, if you notice, it says low grade fever. If the patient is feverish, chill, and also very toxic, or the patient has severe systemic sign and symptom, then obviously you need to go for the antibiotic. But the question is, what is the best antibiotic for an outpatient or inpatient? For outpatient, usually, again, they might get it wrong. The first best antibiotic is amoxiclav. And the second best choice could be sulfamethoxazole, trimethoprim plus metronidazole. The third best option could be ciprofloxacin plus metronidazole. Okay, but if you admit the patient for inpatient, it is ceftriaxone plus metronidazole. So remember the amoxiclav. If you have someone, an elderly who requires antibiotic but needs to be treated as an outpatient, amoxiclav is the best choice unless the patient is allergic to it or unless the patient has already tried it but it didn't help. The next best option is trimethoprim sulfamethoxazole plus metronidazole. If the patient is allergic to sulfa medication, then you switch it to ciprofloxacin plus metronidazole. Good. Do not forget it. I have seen it in MCCQ1, and I have seen it, not seen it, but I mean, not MCCQ1 real exam. I'm just saying that in question banks, okay? And it has been very commonly asked question if you're dealing with a acute diverticulitis in a NAC, they will definitely ask you. So what is your treatment? So I do this, this, this. Okay, what if the patient requires antibiotic? Okay, I will provide them. Okay, what kind of antibiotic? What is the best choice for this patient as for the outpatient? Do not forget amoxicillin. So for the NAC, they will ask you like this one. And for the MCQ one, they may ask you what is the best first choice for the patient who has to be treated with antibiotic as an outpatient, amoxicillin. Okay, do not forget. When to suspect complicated disease, peritonitis, sepsis, severe pain, inability to tolerate per oral, abscess, perforation, obstruction, fistula, immunocompromised, frail, lower threshold to treat and admit. So I think these are very obvious. Uh, we're not going to talk about it. Practical OSCE plan. Explain diagnosis and uncertainty clearly. Supportive care. So if I have acute diverticulitis. So explain why you go with this one. Let's say they give you a scenario in the uh, behind the door and the file holder. You have the file of an elderly who has low-grade fever, and the patient has left lower quadrant pain. So you explained why you go with that because this is a characteristic picture of a patient with a diverticulitis. So what do you do for him? I start with the supportive care. So what do you do for supportive care? I would do if he is not asking, then you continue explaining it. Okay. So do not stop supportive care and then stop. If you say supportive care and he's like, okay, go ahead, then it means you have to elaborate. So by supportive care, I mean I start the fluid, analgesia, diet as tolerated, and if antibiotics, cover gram-negative, anaerobe, local protocol. And so, okay, what kind of antibiotic? This patient is supposed to be discharged. So what antibiotic are you going to choose? Amoxicillin, right? Let's say he is allergic to that. What is your next best option? Trimethoprim, sulfamethoxazole, plasmetronidazole. Good, but the patient is allergic to sulfa. So my next option is Ciproflox plus metronidazole. Thank you very much. And you get 20 out of 20. Safety net, worsening pain, fever, vomiting, inability to drink, syncope, return immediately. Okay, now you want to discharge your patient. What do you do before you discharge the patient? Remember, you do not discharge the patient unless you have a proper follow-up plan for the patient and a precautionary steps explained to him. For example, we discharge you, but you need to see your family physician by, let's say, 2 weeks or by 1 week. Really depends from condition to condition, right? By 2 weeks, for example, just an example. By 4 weeks, you have to see, for example, a psychologist or a surgeon or oncologist, whoever, right? So these are the follow-up that he has to do. But what what are those things that he has to know that if they happen, he should immediately come to you or the nearest emergency room? This is essential. You cannot discharge the patient without doing these steps, regardless of if you are doing the discharge. Okay. For example, if your symptoms starts to get worse, or if, for example, if the pain gets worse, if the fever is spiking, if vomiting is getting worse, or if even you start vomiting, or for example, inability to drink or eat, or if you start to have syncopes, then return immediately or go to the nearest emergency room. When you say this, again, you get 20 out of 20. You cannot discharge without saying all these steps. Okay, follow up, and then when the patient needs to come immediately back to you or emergency room. So gastric pain, pancreatitis, PUD, perforation, and acute coronary syndrome mimics. So I think we did talk about acute pancreatitis, right? Typical, it will be epigastric pain relating to the back, elevated lipase. Again, I should have mentioned that the pain will get better when the patient lean forward, but when the patient lean backward, it gets worse. These are the characteristics. Early Eternal nutrition and early oral diet, if mild, is recommended. Avoid prophylactic antibiotic. We don't use antibiotic for pancreatitis because usually the antibiotic could be a reason or a trigger for the pancreatitis. Okay? Unless it is infection. Unless infection is suspected, obviously. Otherwise, we don't use it because the antibiotic itself causes the pancreatitis. And one more thing, for the pancreatitis, they might test you on antipsychotic, especially valproic acid. Okay, valproic acid, they may give you a scenario about somebody that who has some bipolar disorder, and like they never ask you which medication to avoid, but remember that valproate is one of those medications that you need to avoid in patient with a pancreatic pancreatitis. Don't miss, acute coronary syndrome can present as an epigastric pain. If the patient is elderly, the patient has epigastric, upper epigastric pain, always do ECG. Okay? Perforated ulcer, sudden severe pain, peritonitis, and free air. I don't know if you guys did today the simulation exam. We had free air and peritonitis and perforated ulcer. I don't know if you guys remember it. So assess severity, vitals, organ dysfunction, and fluid status. So OSCE phrasing, how do we phrase it? So we will check your heart tracing and pancreatic enzyme. So the patient has epigastric pain, right? And the patient says that I have epigastric pain, but when I lean forward, it gets better. When I lean backward, it gets worse. So again, it cannot be only pancreatitis because my patient is elderly. So it could be heart issue as well. It could be MI. It could be precarditis because in precarditis, we also have chest pain that gets better when you lean forward and it gets worse when you lean backward. So I have to check the ECG to rule out for the elderly, at least lower MI. Okay. And I check for the lipids as well because if it is abnormal, it is more likely to be pancreas. But if the ECG is abnormal, it is probably the heart. I will start the IV fluid and pain control and reassess frequently. We will decide on imaging and admission based on severity. All right. So renal colic, typical. Colicky flank pain, radiating to groin, patient often restless, like this one. So we have the picture. I don't know how to, yeah, this way I can, just give me 1 second. Sorry, guys. I can just use this. Here we go. So colicky flank pain radiating to the groin. Patient often restless. So this is how it's gonna radiate. For the female and also for the male, same way, testicle on the same side. So urinalysis hematuria, but it's not like, it is very common, but it's not universal. It's not universal. But hematuria, if the patient has flank pain, hematuria, it is usually likely to be stone. But it doesn't mean that's always stone. It could be tumor. It could be something else. It could be very, very, very severe inflammation. Okay? Treat pain, nausea, choosing imaging based on the scenario and risk. Septic stone, infected obstruction. The patient will have systemic symptoms, systemic toxicity plus obstruction. So if the patient has fever, systemic symptoms or toxicity plus obstruction, emergency. IV antibiotic, arginine decompression for a stent nephrostomy, which we did last session. Okay, do not discharge a toxic patient with a suspected infection obstruction. We never do that. We have to admit the patient, right? Because you have sign of infection, this can be, this is the OSCE phrasing now. Let's say you're dealing with something like septic or infectious cause. Now, how do you phrase it? Because you have sign of infection, this can be dangerous if urine is blocked. We will start antibiotic now and involve urology urgently. You will need close monitoring and admission. So we need to admit you. So these are the way you're phrasing when you're dealing with that. Someone who has infectious uh, abdominal pain secondary to infection. So diffuse severe pain. So usually diffuse, if you have, so diffuse severe pain, obstruction, ischemia, and abdominal aortic aneurysm. Diffuse is usually the peritonitis, right? Vomiting, distension, obstination, risk prior abdominal surgery, adhesion, so bowel obstruction, vomiting, distension, obstination, often risk prior abdominal surgery. Usually, if they want to test you, trust me, whether you do the MCQ1 or NAC OSCE, they test you on adhesion. So if the patient has uh, obstruction, the patient has obstruction, bowel obstruction, and the patient has surgery, history of surgery, it is adhesion until proven otherwise. Resuscitate, consider angio-tube imaging, consult as needed. So for the mesenteric pain out of proportion, if you see this, this is 100%. Baker, can you please keep the mic off? Thank you. Pain out of proportion is always mesenteric ischemia. Okay. Consider lactate, CT scan when suspicious, moderate, or high. Do not wait for the late sign. We shouldn't, this emergency, we have to take it to the operating room. So for the abdominal aortic aneurysm, if they want to give you a scenario specifically about this, obviously they're going to give you a scenario about somebody who is older than 50 years of age. The patient would be smoker, the patient would have history of syncope, and also the patient would be fat, the patient would have the history of dyslipidemia, and so on and so forth. So the patient will, in terms of abdominal aortic, if it is rupture, so if it is rupture, the patient, usually they don't give you this emergent case, but they may ask you, older smoker, syncope, hypotension, back pain, abdominal pain that reduced to the back. Now the patient has abdominal and back pain together at the same time. So it is rupture, right? Immediate resuscitation and urgent vascular, consult transfer pathway. Now, this is the part that I was going to talk about. Remember, if you're doing MCQ1 or NAC OSCE, you will be asked this question. If you want to take a note, please take a note because you will be asked and don't confuse it. Two different questions. What is the best screening imaging for the abdominal aortic aneurysm patient? The best imaging is ultrasound. The best screening imaging is ultrasound. The best diagnostic imaging is CT scan. Do not get it confused. Two different words, two different imaging. The best screening imaging is ultrasound. The best diagnostic imaging is CT scan. Do not get it confused. And this is common mistake being done by the IMGs, and they go after the wrong one. The question is asking you the best screening test, and they go and pick the CT scan. And the question is the best diagnostic imaging, they go and choose the ultrasound. Okay, that's the common mistake that happens. Again, if it is a screening, ultrasound. If it's diagnostic, CT scan. Okay, please pay attention. Do not make the same mistake. Admit and observe, obviously, if the patient is unstable, if sepsis, peritonitis, obstruction, ischemia suspicious, obviously, if the patient is toxic and the patient has systemic sign and symptom, you admit, period. Discharge, if it is not very serious, pain control, tolerating per oral, clear follow-up plan. Remember, this is very important. You cannot discharge the patient without a follow-up plan. An explicit return precaution provided. What does it mean? When the patient needs to come back. And it is explained here. Come back immediately if worsening pain, fever, persisting vomiting, black bloody stool, fainting, or new shortness of breath. If you cannot keep fluid down, return urgently. Provide written instruction when possible. So these are the things that you need to do before discharging. So just to sum up, for the opening, introduce yourself, ID the patient. Maybe I should write ID. PT patient, okay? Or maybe write it down. Patient. So introduce plus ID the patient and consent plus your role. Okay. Vital signs, ABC, red flags. You need to cover this. Analgesia, pregnancy status. Do not forget. Data. Focus history, focus abdominal examination. If it is history, it's physical examination. Remember, what is the data? What is the information that you need to provide? You need to have before entering to the station. Am I taking a focus history? Am I doing a focus for abdominal examination? What do I have to do? And also, do not forget about GU and gynae examination if needed. Initial lab test, imaging, rationals. So what is the plan? Working differential. Usually when you do, I think we did have a lecture about differential diagnose. The minimum of differential diagnose is 3, the maximum is 5. So if they are asking you about differential diagnose, always go with 3. Why? Because you don't have enough time to go and justify 5 differential diagnose. Why? Because if you want to do the differential, you need to justify, right? Always put the diagnose, the most likely diagnose, number 1. And why it is your diagnosis, you have to justify it. For example, my patient has acute diverticulitis. The reason I'm going with acute diverticulitis because the patient has characteristic finding of acute diverticulitis. The patient meets the clinical picture of acute diverticulitis. My patient is elderly. My patient has left lower quadrant. The patient has, for example, low grade fever, this and that. So you have to justify it why you want to go with this. My second differential is, for example, let's say obstruction, bowel obstruction. Why I put it as a bowel obstruction? Because this. You have to provide more information and justification. Immediate management, consultation, disposition, net safety. And thank you very much.